Good afternoon. My name is Roseanne Hemmett, and I'm a National Program Consultant with the American Heart Association. I'd like to welcome you to the fifth session of today's Close the Space, Secondary Prevention of ASCVD Care Education, our virtual summit. All presentations will be recorded and available within the coming weeks at heart.org/ASCVD. Today's presentation is titled Benefits of Integrating Pharmacists into ASCVD Management. It's my pleasure to introduce our speaker for today, Dr. Michelle Chu. Dr. Chu is an assistant professor of clinical pharmacy at USC Mann. She went to the University of Illinois at Chicago School of Pharmacy, where she graduated summa cum laude and completed postgraduate residency training in the ambulatory care pharmacy practice at USC Mann. She has worked as a lead clinical pharmacist managing high-risk patients with multiple uncontrolled chronic disease states and has developed various pharmacy services at multiple safety net clinics and health systems. Dr. Chu is a program director for pharmacy residency program and currently practices at LAC and USC Adult Primary Care Clinic. Dr. Chu, the floor is yours.
Thank you so much, Roseanne, for the introduction. I have nothing to disclose. So I'm going to switch a gear a little bit. I know that in the previous sessions, we have heard about the clinical aspects of the cholesterol management and also for the patients who has ASCVD. Today, I wanted to focus more on kind of getting the information out about the transformation in the roles of clinical pharmacists and different settings and understanding the scope of practice and how the effective it is to integrate pharmacists into the care management. So when you think of a pharmacy profession, most people think of a pharmacy. So like such as Walgreens, CVS, that dispenses the medications. But over more than 20 years, the pharmacist has been the critical part of the improving patients' health outcome. I think the main focus here is to make sure that everyone is on the same page and what the data says about the integrating pharmacist. So just a little bit about the history of the pharmacist role transformation. The concept of pharmacists really started before 1920s with the pharmacists spending a lot of time on just compounding medications. But as you can imagine, the quality of medicines probably weren't that great. It could have been concerning. So in 1920s, with the rapid advances and large products of the drugs in pharmaceutical companies started, the need for compounding has dramatically reduced. So starting in 1950s, pharmacists started to shift their main focus from compounding to patient care, where they discuss the medications with the patients. And that happened during outpatient settings. In the inpatient setting at the hospital, they piloted some satellite pharmacies and expanded in that hospital setting. So making pharmacists available on each specialty units or floor. And pharmacists joined in the patient rounding with the medical teams and provided drug information to the medical team. And in 1980s, patient counseling was mandated by law. So non-dispensing activities really expanded to include immunization, medication therapy management, especially for patients with Medicare Part D. So in this era, at the same time, the hospital pharmacists, they continued with order verification, participating in rounding, and they started to specialize in the clinical areas and providing drug information to the hospital staff. I would say the biggest and fastest transformation really happened in the past 10 years. Pharmacists has been actively involved in the population health management. So at outpatient settings, the immunization services have been growing to include PEAS vaccines, providing preventative services and testing, including COVID, glucose, blood pressure, lipid screenings, and comprehensive medication management that evolved from medication therapy management to impact the patient health outcome. At the inpatient side, we did recognize the medication-related issues that could have been prevented the readmissions. So transition of care was a huge effort. So the pharmacist has been part of that TOC to focus on the medication therapies for especially the discharge medicines and the patient's adherence and education. And nowadays, past post-COVID, there's lots of technology advancement. Pharmacists are starting to provide clinical services via telehealth, and also they are involved in digital therapeutic monitoring by collaborating with physicians. So let's go into different settings, how pharmacists are integrated with the healthcare systems. So for outpatient clinic settings, we have federally qualified health centers, outpatient clinics run by health system or VA, Veterans Affairs, and also obviously the physician private offices. All of these outpatient clinics do have offer primary care clinics, but some of them do also have the specialty clinics. So when the pharmacists in most states, they can work under collaborative practice agreement where they can modify drug treatments for the referred conditions. So these pharmacists are additionally trained through residency program and also board certified. So how it happens is physicians and other allied healthcare professionals, they can refer patients to the pharmacists that working at these outpatient clinic settings. So most places probably would prefer patients to be referred to the pharmacist if they are identified as a high-risk patient. So those are ASCVD secondary prevention, patients who have frequent admissions to hospitals or emergency departments, patients who are having trouble with controlling their chronic conditions, such as diabetes, hypertension, dyslipidemia, heart failure. And also patients are having issues with the medication adherence and potentially on polypharmacy. So the making disease management challenging for both patients and providers. So the decision making of who will benefit the most with a pharmacist is really driven by the quality metrics, so such as HEDIS measures or even safety measures from the Joint Commissions and STAR measures from the payers' perspectives. So approaching it more as a population health. So, in a given health system, when there are too many patients who recently experienced one of ASCVD conditions and are back in the hospital frequently, so that the hospital is not meeting the quality measures because maybe the patients weren't receiving statin or were not educated on the statin, the health system actually can target those patients for ASCVD secondary prevention by integrating pharmacists to improve that specific measures. So when patients are referred to the pharmacist, the main roles that pharmacists do is reviewing the entire drug regimens for efficacy as well as safety for all diagnoses that are documented. So they are able to optimize drug therapy for efficacy and safety. They follow the evidence-based dosing for statin, for example, in ASCVD secondary prevention, and also looking at the other appropriate therapy for non-lipid medications for ASCVD secondary prevention, so such as ACE or ARB, SGLT2 inhibitors for diabetes, heart failure, CKD patient, antiplatelet therapies, or beta blockers for post-MI patients, and even lowering triglycerides to prevent pancreatitis, monitoring for safety, side effect, and of course, for the adherence and effectiveness of the drug. They do order and monitor lab, and they definitely assess the medication adherence. So thing about the medication adherence is not that simple. It's not that either patient takes meds or not taking meds. It usually happens when there are changes in doses or in the medications. Patient may not really understand or aware of stopping the previous ones. Maybe they don't even realize that there are new medication that was added to their current regimen, not as a replacement. So this definitely requires the education of the patient, not only educating about the drugs, but also the disease states that the drug is treating for, especially patients with low health literacy, low health numeracy, They need a lot of instructions, but also definitely the motivational interviewing that pharmacists can definitely do. Besides these clinical activities, the pharmacist can often help the physicians on the medication that need a prior authorization, medication access, and help with navigating different formulary from different payers and refills. Another big outpatient setting that you see pharmacists the most is at the community pharmacy settings. And this includes any retail pharmacies, so Walgreens, CVS, Costco pharmacy, any type of grocery-based pharmacies or independent pharmacies. These pharmacies are actually in close proximity with patients' home, mostly within 5 miles. So this is, if you think about it, it's actually closer than the Starbucks. So as far as a location, it makes it very accessible for the patients to get their care if we can offer some clinical services at the community pharmacy settings. The scope of practice, unfortunately, is not as extensive as the outpatient clinic settings that we just talked about in the previous slide. But some retail pharmacies in California, where I am, they provide a similar level of clinical services as the outpatient clinical pharmacist. They provide clinical services under collaborative practice agreement, and these changes really have been driven by the value-based healthcare model for the payers and the health system to try to reach these patients in need for the health access. When fulfilling their roles in dispensing, counseling, and providing medication therapy management, pharmacists at this setting, at community pharmacy settings, can help improve the statin adherence for patients, provide education with the disease state, the medications, and even collaborate with the healthcare providers because they can definitely see the field history of the certain medicines. So, for example, statin, and can inform them on the current adherence status and discuss the plan for that particular patient. Not only about the drug treatments, but they are also addressing preventative cares, right? So vaccinations that required for patients with ASCVD can be an important role that the community pharmacists can play. Lastly, without the OTC products, community pharmacists probably will have a lot more other things to sell, but and also the prescriptive, a lot of prescriptive drugs have been turned into the OTC product. So the advice and the counseling from the community pharmacists are actually really, really important. And they can screen for safety for the patient on prescription drugs and also public to rely largely on these pharmacists for the OTC products. Then what about the inpatient settings? So in the hospital, more pharmacists are specializing in certain areas, so such as cardiology, general medicine, neurology, psychiatry, and they acquire additional trainings through residency and board certified. Their roles mainly occur with monitoring patients for safety and advising medical teams on appropriate drug therapies. Especially when patients are ready to be discharged. These pharmacists help the team and the patients on verifying discharge meds, educating patient on discharge medications, and also follow up after the discharge, especially before they are seen by their outpatient physicians. In the hospital, pharmacists educate the medical teams and staff on the safe and effective drug therapies. They educate nurses on the drug administration. And sometimes they would educate the group of patients and their family members slash caregivers on medications through education groups. So these usually occur in the patients who are long stay patients, mainly in the peds or in the psychiatric unit. Also, inpatient pharmacists with a specialization in infectious disease, for example, they lead the antibiotic stewardship for the entire hospital. So with other specialization like cardiology, neurology, they can be a lead or the part of the quality and safety committees. So I want to talk a little bit more about the evidence. There have been numerous studies and evidences showing the positive impact of pharmacist integration on many different disease states in various settings. But today, obviously, I'm only going to focus on the statin therapy and each different measures. So this study that you're seeing right now, the Montepera et al., evaluated the impact of a cardiology clinical pharmacist intervention upon the rate of high-intensity statins issued at hospital discharge after acute myocardial infarction. This was a pre-post study that included patients with a primary diagnosis of AMI and looked at the proportion of patients prescribed high-intensity statins at discharge before and after the cardiology clinical pharmacist intervention. The intervention that they did was identifying the patients who are eligible and advising the team through rounding and other communications that were all documented. So with post AMI, we know that most patients should be on high intensity or highest dose of a statin that they can tolerate, right? But before pharmacist intervention, as you can see that about 83% of the patients were being discharged with the right intensity of a statin. But after pharmacist intervention, you can see that the proportion rose to 95.4%, which was significantly different from the before. And as you can see, other types of intensities had the utilization of that have decreased. Another study that I want to mention is done by Hillman et al. They evaluated the effectiveness of a post-discharge intervention on the increased use of statins in patients with coronary heart disease. They looked at not only the actual increased use of statins, but also looked at the lipid status and clinical events after 2 years of follow-up. The intervention made by pharmacists significantly increased the lipid monitoring, statin use, and optimal statin doses on the left table. And on the right table 3, you will see that after 2 years of follow-up, there was a big differences in the incidences of the events. There was actually an increase in cardiovascular mortality, recurrent MI, hospitalization for MI, coronary revascularization, higher in the group that did not receive the pharmacist intervention. So again, suggesting that the integration of pharmacists in the patient care can improve not only the right medication, the use of right dose or right indication, but also cardiovascular outcomes. Is Happy et al. They studied the impact of a pharmacist, the population health initiative, on the ability to increase the percentage of the patient with ASCVD who are on an appropriate statin in an outpatient clinic setting. So this is a great example of how health system can use the quality metrics to identify the appropriate patient population for clinical pharmacists to be integrated. So as you can see on the graph, this medical group did not meet their original metric goal. So it was under the goal level of somewhat 80%. But this study is actually interesting because during the first pilot phase, the pharmacists weren't given any prescriptive authority to modify medication therapy. So if you look at this, I hope you can see my cursor, but the green from the first phase here, pilot intervention, you can see that it didn't really change much of their metric goals. Their intervention at the time was just advising the physicians to use appropriate statin, and it was up to the physicians to whether take it or not. You can see them, but when the medical group changed the scope of practice on pharmacists, and they enabled the pharmacists to prescribe, you can see the quality metric not only met the regional metric goal, but exceeded their goal. So you can see from here to here that it actually exceeded their quality metrics. So another measures that I want to talk about is the CMS measures. One of the Medicare Part C and D star ratings is a statin therapy for patients with cardiovascular disease. This measure looks at the percentage of patients who are identified as having ASCVD and were dispensed at least one high or moderate intensity statin during the measurement year. And according to the proportions, you get assigned with a different number of stars. So this matters for pharmacies and as well as health plans, because Medicare consumers is going to look at this number of stars and compare the quality of the different health plans and also the drug plans. With the higher star ratings, the Medicare Advantage plans can increase the revenue by enrolling a lot more patients into their plans. So the plans tend to choose the pharmacists that want to help them achieve these high ratings. And the pharmacist perspective, they need to make sure that they are contracted with the plans, right? So that they can still have the patients come into their own pharmacies. So they are also working hard in increasing these star measures. But when the plans have poor ratings, they are not eligible for any bonuses and could be kicked out of being a Medicare plan. So you can see how integrative pharmacists can help with these ratings from the previous studies that I've shared, and also some of the other examples that I will share. So this study, pharmacist-led cardiac risk reduction model, was done in 2006. That's a long time ago. This was evaluating the American College of Cardiology and American Heart Association and American Diabetes Association guidelines adherence rate before and after the pharmacist clinical interventions. So in this study, about 44% of this study subject had a history of a coronary artery disease. The pharmacist intervention included drug modification, education, adherence, and monitoring. And I'm showing you right now the lab measures here, and you can see the patient's blood pressure, LDL levels, and A1C significantly improved, and more patients were achieving the guideline recommended target levels. Another star measures is on the percentage of a patient whose adherence to statin is about 80% or higher. This adherence is measured by calculating a proportion of days covered. So 80% is set to be the adherence level. What it means is that patients, when it is 80%, this means that patients are picking up their medications um, on time 80% of the time. So if they are picking up more than 80% of the time, that is considered that patients are adherent. And if they are picking up medications on time less than 80% of the time, then the patients are not likely to be adherent. So this is what the CMS measures with the 80%. And as I explained earlier, different adherence levels are assigned to a different number of stars. Daly et al. Studied on the impact of a collaborative pilot program between a third-party payer, local pharmacy organization, and academic institution on improving medication adherence with community pharmacies. And I highlighted two groups that are worth noting. So one group is those patients who are non-adherent but became adherent after pharmacist intervention. And you can see that their adherence measure was measured by PDC, the proportion of days covered. And the number is increased, and that was statistically significant. Another group that worth noting is those patients who were already adherent before the pharmacist intervention and still remained adherent. Even these groups of people, they still had an increase in their adherence measure in number of PDC. The few of the interventions that made a huge impact on these two groups especially was the education, providing pillboxes or reminder system, and also spending a lot of time to motivate the patients to take the medication. Those type of specific interventions made a major difference, especially in the patients who were non-adherent and then became adherent. So in summary, pharmacist's role has been expanded, and now it's a matter of being aware of the scope of practices. Pharmacists improve cardiovascular disease outcomes through medication therapy optimization, monitoring for safety and appropriateness, addressing adherence, and providing education. And also, value-based healthcare and evidence-based medical practices really enable the pharmacist to play a bigger role in patient health outcomes. And lastly, with population health management, pharmacists can have very impactful results when caring for patients with ASCVD. So I will conclude my talk here, and thank you so much. And if you have any questions, you can certainly email me at lee118@usc.edu. Thank you.
Thank you, Dr. Chu. That was wonderful for you to give your email address. We don't have many speakers offer that. That's wonderful. At this time, we'd like to encourage all of our participants to type any of their questions into the Q&A tab at the very bottom of your screen. So I'd like to start with the first question that we got. How do providers start to work with a pharmacist? What's the
Yeah,
starting point?
yeah, that's a good question. So I think the first thing to do is contacting the pharmacy department of the medical center if you are very close to the medical center, or if you are working already at a medical center. Pharmacy department usually will have those outpatient clinic pharmacists who can help with the quality metrics that you want to improve. Another way to do it is to partnering or collaborate with the schools of pharmacy. So because each state, unfortunately, the authority or the scope of practice is slightly different for pharmacists, it could be always a great avenue to work with the school of pharmacy who wants to pilot some great idea that you might have, and then see whether that is worthwhile to expand further. So, and also the benefit of working with the school of pharmacy is that they can provide you with the pharmacy residents and the students, and so a lot more workforce to achieve the same thing.
Wonderful, thank you. Here's our second question. What is the reimbursement structure by working with pharmacists? Could you go into some detail and explain that?
Yeah, so again, the state by state, it's a little bit different, but currently widely used, the reimbursement structure is indirect. So through the chronic care management or fee for services, and if you are part of the ACOs or medical homes, usually they are covered under the capitation. More recently, about 5 states have expanded their reimbursement for the Medicaid. So in state of Maryland, Missouri, North Dakota, Virginia, and Wyoming. And also even California, we do have a law that the pharmacists are being reimbursed, should be reimbursed under the Medicaid. And then the fee, setting up the fee, like how much that would be, is still in works. So I think, again, kind of figuring out the reimbursement structure is not very straightforward. So that's why working with the School of Pharmacies or even pharmacy department within the medical health system would be very helpful.
Wonderful. We have another question here. Is there a way the pharmacist can stop a prescription for an NSAID like meloxicam or ibuprofen 800 to a patient with chronic kidney disease, noting the impact of cardiovascular outcome, not only for CKD progression.
Yes. So if you have a pharmacist within your clinic, based on their scope of practice, yes, they can definitely stop the medication, start the medication, change the doses, and modify the current regimen. The collaborative practice agreement should include not a rigid protocol. It doesn't really state the protocol, but it does say that what the pharmacist can do in general. The pharmacist, the main clinical practice is really following the guidelines. And so what we do at our institution is our collaborative practice agreement does list all the major clinical guidelines. And so any medications that are going against the evidence and it's actually harmful for the patients, then, and as if the patients are my patients who were referred by the physicians, then yes, I will be able to stop that medicine. I just want to add that any clinical activities are left in the documents under the medical chart as that same the same way as the other providers, like the physician's notes. So in my clinic, a lot of the physicians will actually cite our notes into their notes to continue the care process with them when they see their patients.
Great information. Let's see, I have one more question here. Many of my patients have other chronic conditions that need close management. Can pharmacists who I work with for lipid management also manage other chronic comorbid conditions?
So yes, the pharmacists do provide a comprehensive medication management. So which means that we will look at the entire drug regimen and also look at the diagnosis that they have come with. So if the patients are struggling with other chronic disease that and they are not able to get controlled, even if you refer the patients for the statin, for example, that we can work with the patients for diabetes if that is not under control, or blood pressure if that is not under control, or even just looking at their OTC medications or other medications that they may be taking but probably do not have a proper indication. Then we can also discuss with the physicians to stop the medicine.
That's really good information. Right at this time, we don't have any other questions that came in, but I would like to give you another opportunity because we have a few minutes left. And if there's anything else that you might want to add to your presentation, Dr. Chu.
I think I know that throughout the COVID, the pharmacies, especially the community pharmacies, starting with the COVID testing, they were also allowed to provide the COVID drug treatment. And so I think there is some momentum to advance the pharmacy professions, but I think our profession is really the profession that is highly underutilized. Although we do go through extensive trainings, and beyond the school, we do go through the residency program. So I think my talk today was able to help you to get to the same level with everybody else, that this is just a general information about, okay, this is what the pharmacist can do at different settings, and how the physicians, as a physicians, can utilize a pharmacist so that it can help with their quality metrics and their patients, and how we can integrate the pharmacists as a team. I hope that was very helpful.
It was very helpful. At this time, if there's no additional questions, I'd like to just talk about what's coming up next. So at 2:15, we have our final plenary session, session 6. It's maintaining health equity for ASCVD in rural areas. Very interesting topic. At this time, please use the return to lobby link on your screen to choose the last presentation from the list. Thanks very much for attending today's virtual summit. Thank you, Dr. Chu, for your presentation. It was wonderful, and we look forward to seeing you shortly.
Thank you for having me.